Hello guys, welcome back. This is the part 2 of the ECG tutorials, and here you will going to learn the basics of 12-lead ECG. Okay, how does the 12-lead ECG work? First, we need to clarify the difference between ECG leads and ECG electrodes. An ECG electrode is a conductive pad which is attached to the skin to record electrical activity. The data gathered from these electrodes allows the 12 leads of the ECG to be calculated. Example: lead 1 is calculated using data from the electrodes on both the right and left arm. In other words, an ECG lead is a graphical description of the electrical activity of the heart, and it is created by analyzing several electrodes. Okay? Now, these are the electrodes used to generate a 12-lead ECG. The chest and the limb electrodes. Okay, there are 6 chest electrodes. These are the V1, V2, V3, V4, V5, and V6. They are color-coded. V1 should be placed on the 4th intercostal space of the right sternal edge. V2 should also be placed on the 4th intercostal space but at the left sternal edge. V3 is placed on midway between the V2 and the V4 electrodes. Therefore, you need to place first the V4 electrode before the V3. So, V4 is placed on 5th intercostal space in the mid-clavicular line. And then, V5 should be placed on left anterior axillary line at the same horizontal level as V4. And then, V6 is also placed on the left mid-axillary line at the same horizontal level as V4 and V5. Okay. The limb electrodes are right arm, left leg, right leg. Therefore, they are placed on the same corresponding extremities. The standard ECG has 12 leads. 6 of the leads are considered limb leads because they are placed on the arms and legs of an individual. The other 6 leads are considered precordial leads because they are placed on the torso or precordium of an individual. The 6 limb leads are called lead 1, 2, 3, AVL, AVR, and AVF. The term A stands for augmented, as these leads are calculated as a combination of leads 1, 2, and 3. The 6 precordial leads are called leads V1, V2 to V6. Note that the term unipolar and bipolar leads are not recommended because all leads are bipolar since they compare the electrical currents in 2 measurement points. Okay, here is the anatomical aspect of the precordial leads. It is important to understand which leads represents which anatomical territory of the heart, as this allows you to localize pathology to a particular heart region. For example, if there is ST elevation in leads V3 and V4, it suggests an anterior myocardial infarction. You can then combine this with some anatomical knowledge of the heart's blood supply to allow you to work out which artery is likely to be affected. Example, left anterior descending artery, because ST elevation suggests that this is an anterior myocardial infarction because of the V3, V4 ST elevation. Alright, the V1 and V2 are the septal leads. Primarily observes the ventricular septum but may occasionally display changes originating from right ventricle. Note that none of the 12-lead ECG is adequate in diagnosing right ventricular infarction. However, in such scenario, it is recommended that additional electrodes be placed on the right chest which is placed on the same anatomical landmarks of their left side counterpart. These leads are V3R, V4R, V5R, and V6R. So this is subject for next discussion. Alright, moving on. The V3 and V4 are the anterior leads which observes the anterior wall of the left ventricle. Then V5 and V6 are the anterolateral leads which observes the lateral wall of the left ventricle. Alright, how about the anatomical aspect of the limb leads? Lead 1, AVL, AVR are called lateral limb leads. They primarily observe the lateral aspect of the left ventricle. Lead 1 is calculated by analyzing activity between the right arm and the left arm electrodes. AVL is calculated by analyzing activity between right arm plus left leg towards left arm. And then the AVR is calculated by analyzing activity between left arm plus left leg towards right arm. Alright, how about lead 1, lead 3, and AVF? They are called inferior limb leads, and they primarily observes the inferior aspect of the left ventricle. Lead 2 is calculated by analyzing activity between the right arm and the left leg electrodes. And then lead 3 is calculated by analyzing activity between the left arm and left leg electrodes. And then the AVF is calculated by analyzing activity between right arm plus left arm towards left leg. So here is the summary illustration of the anatomical aspect on an ECG. As you can see, leads 1, AVL, V5, and V6 represent lateral wall of the heart. Leads 2, 3, and AVF represents inferior wall of the heart. Leads V1 and V2 represent the septal area of the heart, and leads V3 and V4 is the anterior wall of the heart. Okay? An injury may not be limited to just one region of the heart. For example, anterolateral infarction. So in this case, you can see changes in leads V3 and V4, which is the anterior wall, and also in leads 1, AVL, V5, and V6, which is the lateral wall. Alright, another 12-lead ECG basic we must know before we can able to competently interpret ECG is the cardiac axis. In healthy individuals, the electrical activity of the heart begins at the sinoatrial node, then spreads to the atrioventricular node, and then spreads down to the bundle of His and then Purkinje fibers to cause ventricular contraction, right? Whenever the direction of electrical activity moves toward a lead, a positive deflection is produced. Whenever the direction of the electrical activity moves away from a lead, a negative deflection is produced. The cardiac axis gives us an idea of the overall direction of electrical activity. It can be normal, leftward or left axis deviation, rightward or right axis deviation, or indeterminate or the northwest axis. The QRS axis on an ECG is the most important to determine. However, the P wave or T wave axis can also be measured. To determine the QRS axis, the limb leads need to be examined. The depiction of the standard leads and their relationship to the cardiac axis is here. I want you to memorize this image. Although memorizing this picture is crucial to accurately determine axis, there are some shortcuts to quickly determine the axis. So this image here is easier to memorize than the other one. Okay, the normal QRS axis should be between -30 and +90 degrees. Left axis deviation is defined as the major QRS vector falling between -30 and -90 degrees. Right axis deviation occurs with the QRS axis between +90 and +180 degrees. Indeterminate axis is between positive or -180 and -90 degrees. The fastest non-specific method to determine the QRS axis is to find the major direction of the QRS complex, either positive or negative, meaning upward deflection or downward deflection. And this is in leads 1 and AVF. Okay, here is an example of normal axis deviation. If the QRS complex is upright, meaning positive in both lead 1 and lead AVF, then the axis is normal. This image demonstrates normal axis with the electrical vector heading toward the positive of lead 1 and the positive of lead AVF, as indicated by the arrows. The QRS axis is thus falls within the normal range. This is an example of left axis deviation. If the QRS is upright in lead 1 and downward in lead AVF, then the axis is between 0 and -90 degrees. However, recalling that left axis deviation is defined as between -30 and -90 degrees, this scenario is not always technically left axis deviation. In this case, the QRS axis could fall between 0 and -30 degrees, which is within normal limits. To further distinguish normal from left axis deviation in this setting, look at lead 2. It is negative because it is downward. Then the axis is more towards -120 degrees, and left axis deviation is present. If the QRS complex in lead 2 is upright or positive, then the axis is more towards +60 degrees and the QRS axis is normal in that case. Okay, this is a right axis deviation. So if the QRS is predominantly negative in lead 1 and positive in lead AVF, then the axis is rightward or right axis deviation. As you can see in this image, lead 1 is negative, which is negative positive 180 in the Cabrera system, and positive in AVF, which is positive 90 degrees. Therefore, it is right axis deviation. This example here is a case of indeterminate axis. So if the QRS is downward in lead 1 and downward in AVF, then the axis is indeterminate, or sometimes referred to as north axis deviation or far left axis or far right axis. This finding is uncommon and usually from ventricular rhythms. However, it can also be from paced rhythm or lead misplacement and certain congenital heart disease. Okay, that's it for now. The next video is the 10 steps on how to interpret 12-lead ECG. Thank you.